of around 540 deaths per 1 lakh live births. Next slide. Now, what is the etiology of postpartum hemorrhage? As Tone uterine atony, that is the inability of the uterus to contract, which may lead to continuous bleeding. This is very commonly seen, especially in cases of multigravidas. Second is thrombin problems, that is coagulopathies, that is failure of clotting. Trauma, there can be uterine trauma or injury to birth canal, rupture, uterine inversion, and lacerations. And the fourth T is tissue, that is retention of placenta, clots, and abnormal placenta. So what are the clinical findings of postpartum hemorrhage? Typically, we can see abdominal tenderness, there'll be circulatory collapse, there is increased abdominal girth because of the collection of blood, loss of uterine contractions, maternal tachycardia, and there can be vaginal bleeding. We can categorize it as to mild, moderate, and severe based on the degree of shock. 1000 to 1500 ml is a mild shock, moderate is 1500 ml to 2000 ml, and severe is 2000 to 3000 ml. With mild shock, there is mild compensation of the blood pressure. With moderate shock, there is marked fall of the blood pressure. And in severe, there is almost near collapse of the blood pressure. What are the symptoms and signs? In mild shock, there is weakness, sweating, and tachycardia. In moderate shock, there is restlessness, pallor, and oliguria. And in severe shock, there is collapse, air hunger, and anuria. So how do we diagnose postpartum hemorrhage? In the initial evaluation, there should be a rapid assessment of the patient's status. There is generally the presence of tachycardia and hypertension, and there should be assessment of vital signs and blood loss. At the examination at the time of hemorrhage, there should be an assessment of the entire genital tract for lacerations, hematomas, and signs of uterine rupture. Manual examination for retained placental tissue, and assessment with the bedside ultrasound to check if the uterus is contracted or not, and the evaluation of uterus to check for uterine inversion. Laboratory assessment can be done by doing a complete blood count to check hemoglobin, hematocrit, and platelets. Coagulation studies for the assessment of the coagulation factors like thrombin and fibrinogen. So what is the approach towards postpartum hemorrhage? If there is poor uterine tone, on abdominal palpation, we find the uterus is relaxed, boggy, and soft. The uterus fundus may be felt above the umbilicus if the cavity is filled with blood clots. In this condition, full blood count has to be done, coagulation profile, urea and electrolytes need to be done. And if the patient is not responsive to fluid and blood replacement, then abdominal ultrasound to exclude uterine rupture and intraperitoneal bleeding. The management is to use uterotonic agents like oxytocin and prostaglandins and ergotalcaloids and uterine balloon tamponade. And if this is also not working, then we have to directly follow the hemostasis algorithm. That is first the medical management followed by surgical management. In cases of tears and trauma, we should check for bleeding from the areas of trauma with genital tract. They can also be uterine rupture and extension of the uterine angles in cesarean sections and tears during cesarean section. They can sometimes be extragenital causes such as subcapsular live rupture. Excuse me, previous slide. Subcapsular live rupture or rupture of ovarian and splenic vessels. The investigations, inspection during the cesarean section by exteriorization of the uterus. Ultrasound may help in identifying the free fluid in patients with uterine rupture. What is the management? Repair of the identified genital tract trauma and pelvic arterial embolization in case the other measures do not work. And in cases of retained tissue, retained placenta and membranes identified during bimanual examination, the investigation is examination under anesthesia. What is the management? We have to manually remove the placenta through extraction under regional or general anesthesia. In cases of coagulopathy, there is generally continuous bleeding with a contracted uterus, which is very characteristic in coagulopathies. The investigations are urea and electrolytes, full blood count, and a typical coagulation profile. What is the management? The medical management is immediate replacement of blood and coagulation factors and platelets, and surgical only with trauma and atonic hemorrhage. Unresponsive to medical treatment, we have to go ahead with surgery. Whatever is the cause, we have to attempt to identify the cause and then respond accordingly. Next slide, please. So what is the rationale for development of carbetocin in a new heat-stable formula? Now, carbetocin is available in room temperature, stable formulation, and convenient vial presentation. Oxytocin and ergoid alkaloids should be kept in a refrigerator to avoid degradation. Heat-stable formulation of oxytocin is currently not available. The previous formulation of carbetocin would also have to be stored between 2 to 8 degrees, and especially in poor resource countries, they do not always have the cold chain transport and the required storage capabilities. And for all these things, a need for refrigeration is mandatory. However, carbetocin is stable at room temperature. It has a shelf life of 24 months at 30 degrees centigrade and 75% humidity. It avoids the need for cold chain storage and logistic, and it is provided in a convenient vial. Next, please. So, the use of uterotonic agent. The timing of administration should be either at the crowning of baby's head or the delivery of anterior shoulder at the end of second stage of labor following the delivery of placenta. Prophylactic uses for prevention of PPH and active management of third stage of labor. Therapeutic uses when there is management of postpartum hemorrhage. So, what are the uterotonics that we currently have? We have oxytocin, carbetocin, ergometrin, which is the ergot alkaloids, and symptometrin, which is a combination of ergometrin or oxytocin, and misoprostol. Next slide, please. So, what is carbetocin? This is a next generation drug for postpartum hemorrhage management, and it was created by making several modifications to the current oxytocin structure. It has a prolonged half-life and it reduces enzymatic degradation. So this drug is a synthetic long-acting analog of oxytocin. What is the therapeutic indication is to prevent postpartum hemorrhage due to uterine atony. What is the posology and administration? One vial contains 100 microgram of carbetocin in 1 ml solution for injection. Next slide, please. So what is the clinical evidence when it comes to carbetocin? Next slide, please. So brief description is that oxytocin is a synthetic cyclical peptide form of the naturally occurring posterior pituitary hormone. It binds to the oxytocin receptors in the uterine myometrium. It stimulates contraction of the uterine smooth muscle by increasing the sodium permeability of the uterine myofibrils. It is given either by IV or IM. IV, it's almost an immediate action with peak concentration after 30 minutes. IM has a slower onset, taking 3 to 7 minutes, but produces a longer lasting effect up to 60 minutes. And the half-life is typically 1 to 6 minutes. Storage and transport for oxytocin is it requires protection from sunlight and storage at 2 degrees to 8 degrees continuously to preserve its activity. What are the clinical indications of oxytocin? It can be used for induction of labor, augmentation of labor, prevention of PPH, and in the active management of PPH. Whereas heat-stable carbetocin, this is a long-acting synthetic analog of oxytocin with agonist properties. It binds to the oxytocin receptors in the uterine smooth muscle, resulting in rhythmic contractions, increased frequency of existing contractions, and increased uterine tone. With IV and IM both, it can be given. With IV, there is sustained uterine contractions within 2 minutes, and it lasts for 6 minutes, followed by rhythmic contractions for about 60 minutes, which is 1 hour. In IM, there is sustained uterine contraction lasting for 11 minutes and a rhythmic contraction for about 120 minutes. And the half-life is 40 minutes. What are the storage conditions? It can be stored up to 30 degrees centigrade. It doesn't require a cold chain transport. The heat-stable carbetocin, it is used as a clinical indication. It is used only in the prevention of postpartum hemorrhage. Next slide, please. So, there is a WHO, the World Health Organization champion trial, which has shown that the carbetocin is not inferior to oxytocin. All the results were at par with oxytocin when it comes to different parameters. Okay, the carbetocin is a champion is a carbetocin hemorrhage prevention, the largest clinical trial in the prevention of PPH. This is a trial conducted by WHO, Department of Reproductive Health and Research. In the study design, there is non-inferiority, double-blind, and randomized trial. The objective is to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of postpartum hemorrhage after vaginal birth. Total patients enrolled by 30,000 women across 10 countries, including India. And the primary outcome was to measure the proportion of blood loss of at least 500 ml or the use of additional uterotonic agents. And the proportion of women with blood loss of at least 1,000 ml were taken into account. Next slide, please. Carbetocin, the different parameters were measured in this. Blood loss of greater than 500 ml or the use of additional uterotonic was used in about 14% of patients with carbetocin and only 14% with oxytocin. Blood loss of greater than 1,000 ml was seen in only 1.5% of patients with carbetocin and 1.45% of patients with oxytocin. And when it comes to adverse effects, at least one unanticipated adverse effect was seen in 4% of patients when carbetocin was used and 4.7% when oxytocin was used. And at least one serious adverse effect occurred when 0.7% of patients were given, in patients given with carbetocin, only 0.7% has adverse effects, and among the oxytocin group, only 0.6%. The frequencies of the expected adverse effects did not differ significantly between the two groups. Now, the frequency of blood loss of at least 500 ml or the use of additional euthyrototic agents with carbetocin was proven to be non-inferior to that of oxytocin. And the use of additional euthyrototic agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. So, the conclusion of this champion trial was carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml, or the use of additional euthyrototic agents were also not there in this trial. Next slide, please. Coming to Cochrane review, carbetocin for prevention of PPH. In this review, there was data from 11 studies involving 2,635 women. The author concluded that the women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic euthyrotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of postpartum hemorrhage for women who have vaginal deliveries and is associated with significantly fewer side effects. Next slide, please. So what are the guideline recommendations across the different associations all over the world? The WHO 2018 has suggested that only one of the following should be given for PPH prophylaxis, and one of it is carbetocin along with oxytocin, misoprostol, ergometrin, and oxytocin and ergometrin combination. The SOGC Canada has recommended carbetocin, only carbetocin, 100 microgram IV bolus over 1 minute. And the New Zealand Obstetric Gynecology Society has recommended active management of third stage of labor with prophylactic euthyrotonics. The FIGO body has suggested carbetocin is one of the recommendations for postpartum hemorrhage management. Germany, Austria, and Swiss bodies have recommended the use of carbetocin 100 micrograms slow IV over 1 minute. HCOG, that is the Obstetric Society of France, has recommended carbetocin on proving non-inferiority of oxytocin, which is achieved by the champion trial. Next slide, please. So, coming to my experiences with carbetocin, the first case is a normal vaginal delivery. G2P1L1, 25 years with a gestation of 39 weeks, 5 days with previous uncomplicated normal vaginal delivery. She was admitted in active labor. In the present pregnancy was uncomplicated with regular antenatal care and no known risk factors for postpartum hemorrhage. The first and the second stages of labor, there was uncomplicated progress, and the delivery was spontaneous vaginal delivery, healthy baby girl who was 3.8 kgs. In the third stage of labor, a single IV bolus of 100 microgram of carbetocin was administered slowly over 1 minute, immediately after the delivery of baby and clamping of cord. The estimated blood loss is around 200 ml. The uterine tone after the injection was well contracted immediately, and patient did not need any additional euthyrotonics. And post-delivery, patient had no secondary PPH, no side effects, and discharged with stable vitals. In this case, the use of carbetocin is justified because it is a second gravida and vaginal delivery. In such cases, there is definitely an increased chance of postpartum hemorrhage. Next slide, please. Second case, primary gravida, 27 years with gestation of 39 weeks with frank breech presentation for elective cesarean section. Present pregnancy was uncomplicated with regular antenatal care, and there was no known risk factors for postpartum hemorrhage. And the delivery was done by lower segment cesarean section. A male healthy baby boy was delivered, 3.1 kg with clear liquor. And the third stage of labor, a single IV bolus of 100 micrograms of carbetocin administered slowly over 1 minute immediately after the delivery of baby and clamping of the cord. The estimated blood loss was around 600 ml. After the injection, the uterine tone was firm and well contracted. Patient did not need any additional euthyrotonics. Post-delivery, the patient had no secondary postpartum hemorrhage, no side effects seen, and hemodynamically, the patient was stable and discharged with stable vitals. In this case, generally, breech deliveries, there is an increased chance of postpartum hemorrhage due to overdistension of the uterus, as well as due to the extra manipulation or the prolonged manipulation which is done during the breech extraction. Next slide, please. Third case is in high-risk pregnancies. 34-year-old woman, gravida 3, para 1, living 1, and abortion 1, at 38 weeks, 2 days of gestation, with previous cesarean delivery, with low-lying placenta and a high BMI. She was obese, BMI of around 34, with a history of postpartum hemorrhage and previous delivery was admitted. Since It is a post-cesarean delivery. We had planned an elective cesarean delivery at 39 weeks under spinal anesthesia with active management of third stage of labor. Intraoperatively, the patient was monitored with ECG, non-invasive blood pressure, and SpO2 continuous monitoring. A large bore IV access was ready because taking into consideration all the high risk factors that she has. A blood cross-batch sample was also done, and 1 unit for Paxils was reserved, and the patient and the attendant were also counseled. Lower segment cesarean section was done and delivered a male baby of 3.2 kg, clear LICA, and delivered placenta and membranes. Third stage management is immediately after the baby delivery and cord clamping, a single IV bolus of carbetocin of 100 microgram was given. The uterus was well contracted and no further bleeding was there and no further uterotonics were required. The estimated blood loss is around 550 ml, which is acceptable for cesarean sections. Post-operative, there was close monitoring of the blood pressure, heart rate done at every hour, and no secondary PPH was seen. But there were no side effects seen, and she was discharged with stable vitals. As we have seen in this case, the patient has a very high risk probability of a repeat postpartum hemorrhage since she already had it in the first pregnancy. She is obese, and there was a previous cesarean delivery, and also there was low-lying placenta. So in this case also, carbetocin was used, taking into consideration all these things. Next slide, please. Next slide, please.
Yeah. Thank you so much, madam. Thanks for your case studies.
Yes.
I mean, in all these cases, madam, when you use carbetocin, you use IV form or the intramuscular?
We use IV form.
IV form.
Yes,
and you've been using carbetocin how long?
We've been using for 1 year, sir, almost.
Almost 1 year, yeah. And any untoward side effect you have seen?
No, sir.
No. And this question, which is the patient profile where doctors can anticipate PPH? Of course, you can anticipate PPH in any patient, but in
Yes.
generally
We can anticipate when there is a over-distended uterus, polyhydramnios, or there is any medical comorbidities, previous history of postpartum hemorrhage, anemia. Generally, these are the conditions where we anticipate postpartum hemorrhage, but I think the most dangerous one is where we do not anticipate any PPH and suddenly we land in
Absolutely. Expect the unexpected is what happens in gynecology many times.
Exactly.
Yeah. Suddenly something turn happens. Anemic patients are also prone for PPH, I suppose.
Definitely. Anemia
in our country, in our country,
that is very much possible, and it is a very dreaded complication.
Yeah. Can we use carbetocin in case of retained placenta?
Actually, we shouldn't be using carbetocin because it's a very strong uterotonic. So only after the complete delivery of placenta should we give carbetocin, and even in retained placenta, we can't give unless all the bits are removed.
Yeah, of course. After MRP is done here.
Yes, correct.
And RH negative mothers, any experience you have had?
RH negative mothers also we can regularly give carbetocin, sir, because RH negativity has nothing to do with uterine tone and uterine contraction.
Yeah.
So it is in no way related. Yeah.
Now, many of us use oxytocin for labor induction. So can we use carbetocin for prevention of PPH in that case?
Definitely, because oxytocin is, since we are used for labor induction, postpartum hemorrhage, it is completely washed out by that time.
Yeah.
So definitely in such cases, we can use and we should use carbetocin, especially when we use for oxytocin for labor induction, because they are, they are a high risk for postpartum hemorrhage once we induce and the patient.
I mean, you've generally been preferring IV routes, so this question doesn't really apply. Any side effects you have seen with carbetocin? God bless, you should never see. Yeah.
As of now, no, but yeah, we've come across articles where there were deadly complications of carbetocin, but luckily we have not seen complications.
Madam, have you seen any side effect, ADH-related side effect with oxytocin? That's a general question. Because people say a lot about this ADH side effect with oxytocin.
Oxytocin, typically, I mean, if we give bolus, in some cases there is headache and there's hypotension, but we have never gone to that level. We prefer giving other uterotonics rather than giving the bolus, higher dose of bolus of oxytocin.
And if a patient is not responding adequately with carbetocin, then what do you do next?
And definitely, we have to resort to other uterotonics.
Everything, of course.
Everything, methogen and carbifrost and maybe mechanical measures like uterine tamponade. Again,
do you repeat the dose anytime?
Carbetocin, we don't repeat the dose.
Because that's not recommended also.
It is not recommended, and there's no point because it's anyway, it is long acting and it is not working. It is just a waste of time.
Absolute. And we are wasting time in overall.
Exactly, we are wasting time.
Specific advantage of carbetocin over other
Carbetocin, one is that it is completely heat stable, so we do not have to worry about the cold
storage.
chain maintenance, and it is long acting, so we do not have to keep checking again and again for the next 3-4 hours whether the patient is bleeding or not. So that is a very good advantage of carbetocin when compared to oxytocin or other uterotonics. And other uterotonics are contraindicated in some conditions, like methotrexate should not be given in heart patients and with blood pressure. And carboprost, we can't give it in patients with asthmatics. So these problems are not there with carbetocin. So definitely that is an advantage of carbetocin over the others.
That's good. I mean, you have been using it as a first line, madam, I suppose.
We have been using it at first line because, like I said, it has a longer half-life and there is no maintenance that has to be done. So definitely it is being used as a first line.
We always go for upgrade. Now, if a good drug is available,
Correct,
always choose
exactly.
whichever it is.
Yes.
It is said, many doctors, I mean, this question has come from doctors, if it said, if they fear if carbetocin fails, nothing else works. Is it true?
In our experience, it's not that way, sir.
It's not
Because very rarely we've seen carbetocin failures actually.
And other drugs will have a different mode of action.
Different mode of action,
Yeah,
exactly.
yeah.
So I don't think it is correct.
The role of anesthetist in your settings?
Anesthetist is only to monitor the vitals and yeah, the mode of monitor the vitals one. But once we give the drug, and then he has to just go ahead with how the patient is responding and how the patient is the well-being of the patient. That's it. Choosing the drug is completely a gynecologist decision.
And just to conclude, what is your overall take-home message for the audience?
Definitely, carbetocin is an upgrade from oxytocin. In many ways, it is useful to us and it is very helpful because of all the positive effects that he has, that the carbetocin has. So we have been using carbetocin on a regular basis for a long time, and we'd also suggest the same.
Madam, thank you so much.
Thank you.
Thank you. I mean, it was excellent, listening to your case studies and live experience about using them in different conditions.
Thank you.
And it's always good to see that patients responding because we know PPH is a potentially very dangerous condition.
Exactly,
and without any side effects. Thanks so much for taking your turn.
Thank you, sir. Thank you so much. Yeah.
Thanks all the doctors who took time from the schedule and attended this webinar. I'm sure you must have benefited out of case study discussions. Thank you, sales team. Thanks, Bivas marketing team, and thanks, Nagadevi, for your IT support. Thanks, madam. You can sign off, madam. Wish you a very good evening.
Thank you, sir. Thank you, everyone, and thank you, Hetero Pharma, for giving me this opportunity.
Thank you.
Thank you, ma'am. Thank you so much, ma'am.
Yeah, thank you.
Madam, thank you so much for accepting our invitation once again. And madam, it was really nice having you on this platform, ma'am. So we